Sure.
Okay. Hello, everyone. Thank you, GAPI members and friends and family for joining us for this educational meeting. In our mission this year and vision is to connect and collaborate and knowledge share across the state of Georgia. And thank you, Dr. Vishal Bhalani is here for us. To give us urology update on urology. And Dr. Bhalani, thank you for accepting the invitation. And for this, our educational committee chair, Dr. Amul Takalkar, is here to moderate the event. And with that said, Amul, please take over the podium.
Thank you, Lalitha, and good evening, everybody who's joined this GAPI webinar. I believe this is our fourth webinar, and today we will be talking about an issue that's important to everybody. It's practical urology for patients and loved ones, and we have a very esteemed speaker, Dr. Vishal Bhalani, our very own from Cumming, Georgia. So Dr. Vishal Bhalani received his education at University of Miami. He got a prestigious academic scholarship to the University of Miami, where he earned both his bachelor's as well as medical degrees in a highly competitive 6-year integrated track. It's an honors program in medical education. After his medical education in University of Miami, he moved up north a little bit, not too much. He went to UNC, so University of North Carolina, where he did his internship in general surgery, and then subsequently completed his urology residency training at Northwestern Memorial Hospital. So he did go up a little more north. It's one of the top-ranked hospitals for urology care in the country, so he's well-trained. Then he came back to Georgia in the Atlanta metropolitan area, worked for a large group practice, and then recently he started his own very own. So when everybody else is getting bought up by big entities, he's actually has the ambitious and audacious goal of starting his own setup, which he did, the Bhalani Urology Institute in Cumming, Georgia, where he's trying to bring back a touch of personalized care in urology for both men as well as women who are seeking not only an excellent experience, but even a better clinical outcome for themselves. So we are looking forward to this talk. The session will be for about 45 to 50 minutes, and we'll have about 10 to 15 minutes of questions and answers. If there are any questions that you want to post, you can post in the chat as they come up, and then at the end of the session, we'll address them. And then you can unmute yourself and ask the questions in the QA session as well. So without further ado, Dr. Bhalani, it's all yours. Thank you.
Oh, great. Yep. Thank you for the introduction, and thanks for the GAPI president, Dr. Medapalli, and team for inviting me. I'm honored to speak to everybody today. So, I tailored my talk for obviously for providers who are practicing and also for patients, and because everybody is going to have urologic issues, and so it's just one of those things where it's good to kind of know whether if you don't see patients that have urologic issues, but even for yourselves, because most of us will have some type of urologic issue, which we'll get into. So let's see if I can get this to go. So I always joke that urologists are just plumbers in general with lots of debt, and starting at 30 years old versus regular plumbers. But in general, we're going to talk about benign prostatic hyperplasia today. We're going to talk about overactive bladder, stress incontinence, recurrent UTIs, and hematuria. And then, like I said, if anybody joined late, I'm happy to answer any questions about anything else. I know PSA and screening and all that kind of stuff always comes up, as well as low testosterone and other things. So if people have questions, I'm happy to answer them. But we'll sort of start with just like how I try to explain everything to the patients and keep it simple. The urinary system or the bladder itself is, it's essentially just a balloon. We've got the outside of the balloon, and then we got the outlet of the balloon. And so basically any dysfunction in the storage of urine or holding of the urine is where we're going to get urinary symptoms. So we just try to keep it pretty simple. Storage symptoms, urgency, frequency, waking up at night, people not being able to make it to the bathroom in time, people coughing, laughing, and sneezing, that's a storage problem because there's a weakening of the outlet. Then there's symptoms that people might have when they're urinating. So weak stream, starting and stopping of the stream, taking a second to get the stream started, straining, burning. Those are all just kind of, symptoms that folks might have. And then after urination, dribbling, feeling like they're not emptying, or some patients, although they have urinated, they felt like they urinated, they're so full that they're leaking urine. So just, simple, way to think of it is there's either a problem with holding it or storing it or a leaky outlet. And so just to switch gears to BPH specifically, so about 50% of men will have benign prostatic hyperplasia by the age of 60. About 80% of men will develop BPH. And I always joke with the patients. I tell them it's like taxes. You could try to outrun it, but the government's going to catch up and get their money. It's the same thing with BPH and urinary symptoms. Every man, if we live long enough, will have prostate symptoms. So it's important to recognize for patients. It's important to recognize for loved ones. And the reason is if you, or sorry, let's go for the reason next, but let's talk about the anatomy a little bit. So I like to keep it simple as far as how I explain it to patients. So if you look in the left slide, we've got obviously the fancy picture. I kind of brought it back to the balloon, and I tell people to think of the prostate like an orange. So the urine tube is coming out of the bladder, going through the middle of the orange, and then out of the body. As the fruit in the middle of the orange grows, which happens to us as we age, it squeezes the pipe in the middle. So the orange peel is not stretching as quickly as the fruit in the middle is growing. So that's what puts a squeeze on the pipe. And again, this is going to happen to everybody. As soon as we hit puberty, we start making testosterone, our prostates start growing. And so ultimately, like I said, if we live long enough, some guys will be lucky, they'll make it till they're 100 and not have prostate symptoms, but some guys will sometimes experience it in their 40s. So it is something that most of us will either go through or have someone that we know or loved go through. And so why do we care? So we care similar to like blood pressure. I always tell people the reason that it matters is we don't want these pumps in our body working too hard, because they will work hard and then eventually they'll get tired. And so if you look at the picture at the bottom here, we've got the bladder, which is a smooth muscle. So it's not like your arm or your leg. It's not trying to get stronger, but it will in response to strain. And so in the second picture, you can see the muscle fibers starting to thicken and get stronger. And then in the kind of delayed phase, if someone sort of ignores their symptoms, I probably see a patient at least once a week or every other week that has basically ignored his symptoms so long that he's either having urinary incontinence or hydronephrosis. There's probably folks that you would know at the temple that are going through these issues, wearing pads and sort of suffering in silence and not realizing kind of what the damage they're causing. So, I think the big thing is the bladder dysfunction, much like blood pressure in the heart. I make that analogy commonly because I think patients understand that concept very easily. And then obviously, if you're not emptying the bladder, you're at risk for urinary tract infections, bladder stones. As that urine stays in the water, it's kind of stagnant. And then, of course, incontinence with the overflow, or even irritative symptoms. So just real quick on the urinary symptoms. So as far as the urinary symptoms, so a lot of times guys may not notice weak flow, or they may not notice that starting and stopping or waking up is a problem at night because they're not emptying as well. But they may notice the frequency and urgency of urination. And so often in male patients, I've seen this happen where they'll get prescribed overactive bladder types of treatments when typically the underlying problem in an older patient or an older male patient is going to be BPH. And so the goal of treatment should actually be treating the BPH first. And so we see that often where a patient will come in taking overactive bladder medications, and it's actually worsening his condition, and often not going to be as effective as treating the underlying problem. So I think everybody in general, we're not going to get too much into the science. We'll keep it high level, but so there's alpha blockers. So this is the Flomax, the Rapaflow. It's basically relaxing the smooth muscle of the prostate and the bladder. There's been some evolution in kind of how we think about prostate medicines in general. So there is a side effects related to these medicines There's fatigue, there's sinus pressure, there's dizziness, there's lightheadedness, there's hypotension, and then more recently there was a Medicare study in 2018 that showed that there was increased risk with memory loss or dementia in patients that take these medicines for more than 2 years that are over 65. So it's not without its side effects. I think historically it used to be the lesser of evils. But now, as you'll see when we get through further in the talk, it's not the only treatment option for these patients. It's definitely a good way to proof of concept. So a lot of times I'll have patients start medicines just to show themselves that, oh yeah, okay, my symptoms maybe are worse than I'm letting them on to be. But it's a pretty quick onset medication, and so we often use it. Flomax was the one that that got dinged in this paper for causing this side effect. And so sometimes, just practical, I use a more selective alpha blocker like alfuzosin or silodosin. And then there's the other class of medicine. So there are 5-alpha reductase inhibitors. That's the finasteride and the dutasteride types of medicines. And the way that's working is by blocking the conversion of testosterone to something called dihydrotestosterone. And the idea there is that it prevents the growth or in some cases shrinks the prostate. It can have some significant side effects. There's something called post-finasteride syndrome, which is erectile dysfunction, decreased libido, suicidal ideation. It can happen after a short-term treatment with these medications. It can happen in patients that are using finasteride for hair loss. So it's still, being looked into, but it's definitely a medicine that does have some side effects, and it does artificially lower the PSA by 50%. So that's something to be mindful of if your patient is taking these medicines, and it takes about 6 to 9 months for it to work. So it's not going to be something that sometimes patients get started on this medicine that have a catheter in, and it's not going to work fast enough to get those patients off the catheter. And then the third class of sort of prostate medicines is the phosphodiesterase inhibitor. So Cialis comes in a daily dose. Mechanism of action is not completely understood, but the idea is that maybe it increases the blood flow to the bladder neck and the prostate. Or my theory is that when you can have an erection, who cares about peeing? So there are some side effects related to the medication, just like with Cialis or Viagra. For erectile dysfunction, people can get headache, indigestion or reflux, and stuffy nose. And for treatment, it takes about a couple weeks for the onset of this when we're using it as this low dose therapy. So getting into the question that we had got asked at the beginning of the talk about treatments as far as surgical treatment options. So again, there's this paradigm shift in the treatment of prostate enlargement and BPH. One, that it's important to treat early just so people don't get into end stage problems. And then number two, that medicine is not the lesser of evils or as much the lesser of evils anymore, because the only treatment option isn't the old-fashioned TURP or transurethral resection of the prostate. So I broke down the treatment options here into 2 categories generally. So there's what I would call ablative treatments. So we're going to do something to remove or reduce the size or treat the actual tissue itself. And then there's non-ablative therapies where we're not going to do anything to remove any tissue. So again, if you go back to where's my mouse here? Hold on a second. If we go back to the prostate analogy, so in these various treatments, we're going to try to actually physically remove this fruit, and we're going to leave this orange peel behind. And so in a TURP, that's historically the treatment we've used for the longest time. We use electrocautery for that. Green light is using a laser. HOLEP is using a different kind of laser where we're trying to actually, again, remove all this fruit in the middle. Aquablation is one of the newer versions of this therapy. It's where we're actually going to use a water jet, almost like a pressure washer. I tell people to think of it like a pressure washer. It's a cold water jet that we're going to use to vaporize this tissue here. And then there's Resume, which is basically a steam therapy. So it's hot water versus cold water. And I would say the differences in the therapies, I think, is sort of the heat-based versus non-heat-based on this side of things. I think the heat-based therapies do have more side effects. I think there's more risk of erectile dysfunction. There's more risk of retrograde ejaculation. there can obviously be this transfer of this heat outside, and that's how that affects that. And so, of the ablative therapies, the one that I lean towards the most would be aquablation. It has the lowest risk of retrograde ejaculation of all those therapies. So if anybody's choosing that kind of therapy, that would be kind of the leader on my list of these types of therapies. And then in this other category, we call it non-ablative therapies, right? So how are we going to open up the prostate without removing the tissue? So I think actually the guy that designed UroLift is a cardiologist actually by training. And basically what's happening is we're doing something to open up this fruit in the middle. So with UroLift, we use stitches, which I'll show you in a quick picture in the next slide. Optilume is going to actually use a balloon that we put in there, and it blows up in the prostate. It is drug coated, and that is designed to prevent return of that prostate tissue after time. iTind is much like a stent. It's a little metal cage that we put inside the prostate that opens it up. And then pseudo in the non-ablative category is prostate artery embolization, which is done by the interventional radiologist. And that's also becoming a little bit more in vogue right now for BPH treatments. And so I did a little slide just to show folks kind of the difference. So again, aquablation, I would say, is probably a little bit of a safer option for any kind of ablative therapy. And the idea is basically using a water jet to remove all this purple, which is where the fruit is. It does require a catheter. The durability is similar to any of the other resection types of procedures, like a TURP. It'll last about 7 to 10 years. I tell patients none of the treatments are last forever. They all have a time limit, at least in the moment. None of them are permanent. And again, side effects, bleeding, and there is a risk of ejaculatory dysfunction. Alternatively, if you look at the middle slide, UroLift is kind of like a stent. So instead of putting a big metal cage in there, we tried that many years ago for stricture disease, and it didn't work. And basically the reason that it didn't work is because if there's any metal exposed to the urine, it can get calcified. And so the idea behind UroLift is if you take a stitch, or let's say a grappling hook, and you throw it on the outside of this capsule of the prostate, or the orange peel, and then it catches. And then you push the fruit up against that, and then you're going to lay down another stitch on the inside here, and that basically pushes the tissue up against the orange peel and pulls the prostate open. And so these little stitches are tensioned appropriately, and you put in at however many the patient needs based on prostate size. But the idea is to just forcibly pull the prostate open. And because these things are small enough, the tissue kind of covers it over after about 6 weeks, and so it's not exposed to the urine. It can be done in the office. It can be done under laughing gas or sedation type of anesthesia. There's typically no catheter afterwards. It doesn't have as long a durability factor, so that is a difference. It lasts about 5 years, and there is some short-term burning and bleeding related to the procedure. And then prostate artery embolization is just a completely different treatment, basically going and embolizing these prostate arteries. So less invasive. It's not ablative or non-ablative, and it's non-ablative in a way. It's basically going to just cut that blood supply off to the prostate, and then the prostate tissue will involute basically over time. Doesn't require a catheter. It lasts about 3 to 4 years based on current data, and side effects would be retention, bleeding, and then of course these little spheres that they place traveling to other areas and causing some blockage of other blood vessels that were not what they were looking to block. So that's becoming a little bit more popular these days. And so that's the end of the BPH discussion. Going to switch gears to overactive bladder. So overactive bladder is not a disease. It's a complex of symptoms. It's frequency, urgency, and waking up at night. So frequency, folks that are going more than 8 times in 24-hour periods. So that translates to less than every 3 to 4 hours, which is what's normal. Urgency, not able to wait 15 minutes before giving in to the need to void. And then waking up 2 times or more at night. So once is considered normal, but 2 times at night is considered abnormal, or anything greater than that. And that's disruptive to the sleep cycle. So that's kind of why it's an issue. It's not it's a chronic problem, much like BPH. This sort of puts the body under strain over time. So it's not life-threatening to wake up twice, but it does disrupt the REM sleep cycle. And then about 15% of patients will have urgency incontinence where they can't make it in time and have an accident. Overactive bladder is very common. It's about 1 in 6 adults. It tends to have a higher propensity in women at younger ages, and then men kind of catch up. And the reason, obviously, is as that prostate is growing, that bladder is working harder, and then you get the frequency, urgency, nighttime symptoms related to overactive bladder, typically from the obstructive process of the prostate. So I think one of the biggest things is it's a lot of patients, again, they're managing their symptoms. So if we don't ask, they don't say it. Obviously, in a urology office, all the questionnaires are about urination or sexual function or whatever. And so from our side of things, we're asking those questions. I know in the primary care office that you guys are dealing with so many medical problems, it's probably not even on the list of things to worry about. But it is something that patients will often reduce the amount of fluid they're drinking, drink different types of fluids if they're going out. Some of the patients obviously are wearing pads. Some of them start to wear darker clothes because they know if they have an accident, it won't be able to be seen as well. Many folks take a long time to come and see us. So, the average is about 6.5 years before someone comes to see us. And then about 40% of these patients will just never ask for help. So it's just one of those things where it's sort of, I think, commonplace for patients to think that it's normal. I call those patients my bathroom mappers. They know where all the bathrooms are between home and work, or home and the grocery store, or all the good bathrooms, as my wife would say, ones that are clean. And so, like I said, it's a lot of these patients think it's just normal part of aging, that's not too bad, or everybody else is going through it, or it's embarrassing to talk about, or they might even think that there's no treatment for them. And again, it can be dangerous as well. So waking up at night, there is an increased risk of fractures from falls at night. Again, waking up 2 times or more is considered abnormal. So there's a quality of life also function there. And then, of course, these patients can become a little bit more reclusive if they're not, socializing or anything like that because of their urinary issues. So that can also have a social impact. And so just general, we always go through the diary with them. We have them, try to do distraction techniques. Pelvic floor physical therapy can help sometimes. Obviously, if they're drinking 3 pots of coffee a day, that's always the first place to start as far as those things. Dietary management, they're eating late into the evening, drinking late into the evening. I know Indian culturally, we have a lot of folks that will drink a big glass of water right before bed, and then pee twice at night, and that just is an input-output problem there. And then bowel management, constipation plays a role in these folks. And so those are, just kind of the basics. I think one of the mainstays of treatment that most people know, of course, is the anticholinergics. And so, here's the list of all the different ones and I'm sure people have seen these before. From an efficacy standpoint, there really is no difference. There is some slight differences in side effects and risks related to the different medicines, but in general, there isn't a significant difference in efficacy for these medicines. Why might we not want to use these medicines? So most of our patients, again, with overactive bladder are going to be older. Anticholinergic medicines are listed on the Beers criteria for not being safe in patients over 65. It can cause confusion, dry mouth, dry eyes, constipation, blurry vision. So it's one of these things where we, typically, obviously we prescribe them, but it is one that's not as safe, sort of for long-term use or for side effects or for older patients. The other class of medicines is the beta-3 agonists. So this is the Myrbetriq and the Gemtesa. These are expensive because they're newer. There's no generic. They are better tolerated, I would say, from a side effect standpoint. Myrbetriq specifically can raise the blood pressure a little bit. There is some constipation, some dry mouth. I do see some patients with palpitations. Gemtesa can cause some more GI-related symptoms, diarrhea, nausea. I've seen headache before. And then they're just very expensive. So a lot of times, patients end up maybe taking it, maybe taking samples, maybe taking the medicine for a little bit, but then it ends up being sort of cost prohibitive. So what do we do for those patients for longer term therapies? We'll get into that in a second. And then as far as these medications go, if there are longer acting ones and shorter acting ones, so definitely if you are going to pick any of the anticholinergics, making sure you're using an extended release medication. The medicines that are in the anticholinergics that have been studied in patients over 60 were these four here. Again, I'm not a big fan of the anticholinergics. I think there are a lot of side effects related to that. And I typically try to stay away from those medications just because I personally wouldn't want to trade frequency and urgency for dry mouth, constipation, or dry eyes. And then in men, so again, typically the underlying cause is going to be benign prostatic hyperplasia. And so if they're on treatment or if they've had a prostate treatment and they still have irritative voiding symptoms, those are the patients that could see benefit from these medicines. Typically, we want to make sure they are emptying well. So in our office, we'll check a post-void residual. So after they pee, how much are they leaving behind? If they're leaving a bunch of urine behind, it wouldn't make sense to then go and relax their bladder with one of these medicines so that they can leave even more urine behind, and kind of increase their risk for UTIs or other problems. And so that's something that, again, for men that have overactive bladder, the underlying etiology is going to be BPH, and making sure they don't have a history of retention because these medicines could put them back into retention. So what do we do for the folks that have side effects with medications or want some more longer term type of therapies? So Botox, we've been injecting in the bladder for 20 years. It's originally was for neurogenic bladder or spinal cord injury patients, and it evolved to overactive bladder, which is obviously non-neurologic. It's FDA approved. It's covered by insurance. We basically put a tiny telescope in the bladder, inject the Botox into the detrusor muscle, and it basically paralyzes the muscle just like it would paralyze the facial muscles or for tension headaches or anything like that. So it's a similar concept. It lasts up to 6 months. It tends to have decreased efficacy over time. So some patients might have to get treatments every 3 months, but it can last up to 6 months in some patients. And then there is a risk, of course, from getting a urine infection because we're going from the outside to the inside. And then in some patients, we can't necessarily control the degree of relaxation of the bladder to get into complete retention where they can't pee. That's about 10% of the time. And the good and the bad about that is eventually the Botox will wear off and they'll be able to void as they did before. So it's not a permanent thing, but obviously it can be a short-term quality of life problem. And then the other treatment for long-term or refractory overactive bladder is neuromodulation. And so this has also been around for over 25 years. I think every time I'm trying to explain this to patients or even other folks, I always tell people it's like I'm speaking a foreign language because it's something they never heard of before. And so half of my job is just educating patients that this therapy exists. It's not new. It's FDA approved. And what it does is that the thought process behind overactive bladder is that there's some miscommunication happening between the brain and the bladder. And then this therapy actually is providing that communication. So almost like a TENS unit for the bladder with a sort of simple office-based trial where we basically put these little test wires by the S3 nerve root and kind of by the buttocks. So this is the top of the buttocks. We can stimulate this bladder nerve and see if a patient's going to have a response. It's typically a trial that's done over 3 to up to 14 days technically, but usually about 3 to 5 days. I compare, whenever I'm explaining it, I compare it to like a Holter monitor, an EKG. Basically, if you have an EKG in the office and you're not in an abnormal rhythm in that moment, you're never going to catch it. We put the stickers on folks and we send them home and we see what happens. And then so the same thing here. We do this test and set it up in the office. We send you home. The patients record their urinary symptoms before and after, and we see if there's a response. And if they have a greater than 50% improvement in their urinary symptoms, typically most of those patients will have a pretty even better improvement, usually with longer term therapy. It is sort of, for lack of a better word, a bladder pacemaker. So if someone has a positive trial, here's the implanted device. It is by originally designed by Medtronic, so it looks just like a pacemaker battery. It's again done under some minor anesthesia. The batteries last 15 to 20 years, so it's a good long-term therapy. I think from a cost perspective, quality of life years perspective, it's definitely the best treatment for the long term. And these batteries are MRI compatible, so there's no issues with that. And it's reversible. So if for some reason someone doesn't like it, uh, it didn't work or whatever, it can be removed or reversed. But obviously, the goal is to provide someone with long-term therapy. It is a very successful treatment. So in patients that go on to the full treatment, it's 76% of patients will see improvement in bladder control. Quality of life scores are almost 3 times higher than when patients are on medications. It's also effective for fecal incontinence. So I treat a lot of bowel incontinence patients. They sometimes come together. And because we see a lot of overactive bladder, we ask about bowel incontinence as well on our questionnaires in the office. Bowel incontinence is actually way more common than one might think. It's 1 in 12 adults, which is a very common condition. I think one bowel accident episode is probably a life-changing event, and so I think one is one too many. And so these patients really, this is like a life-changing treatment for them. So it's just sort of a side discussion, which we can talk about if anybody has any questions about it. But essentially, those patients actually see a significant improvement. So it's the same test, same product, and those patients will see almost 80-90% improvement in their bowel issues. And so you'll have patients going from having accidents to not having accidents. That can be a life-changing thing. And then non-obstructive retention is, so interestingly enough, it works for patients that are on this end that have very sensitive bladders, and then it works for patients on this end that have bladders that don't want to squeeze. And it's non-obstructive, so not related to a blockage problem. And we'll get into why that's important when we get into the urinary tract infection section. But many patients actually have non-obstructive retention, and that's an issue or the underlying cause of their urinary tract infections. And so this is a therapy that might help folks like that as well. All right, so just real quick, we talked about urgency and urgent continence. Overflow incontinence, again, is from a blockage, and it's kind of, I think of it like a full cup. The water is all the way to the top of the cup, and anything extra is just spilling over the top. And so that's a dangerous situation, and that happens to a lot of guys in retention, or even in women in retention. So that can either come out because it's so full, or it can back up to the kidneys because it's so obstructed. So, but what we're going to talk about next is stress incontinence, which is coughing, laughing, and sneezing and leakage. And so this is common after childbirth. It's common with aging. It's obviously not a life-threatening problem. It is a quality of life problem, but it's, in general, it's not normal to have to wear pads or liners or anything like that. And so I tell folks, although the commercials on TV might make it think that everybody is wearing a pad or a liner, it's not something that people have to suffer through. And I think a lot of patients, don't know that. So if they're interested, it is a little bit different than overactive bladder. I tell most patients that overactive bladder is a medical problem, unless they have refractory overactive bladder. And I tell folks that stress incontinence is a surgical problem. And the reason for that is if you have stress incontinence and Kegel exercises and weight loss and constipation management and trying to empty your bladder as best you can, so that way you don't have a big accident or a lot of urine in the bladder when you do cough, laugh, or sneeze on accident. If those things don't work, then typically the treatment is surgical or procedural. And there's been a new development in that space, so it's not a new therapy per se. It's a new product that we can use. And so it's called periurethral bulking. So I tell patients it's kind of like fillers. So like folks that are getting fillers in their lips or fillers in their butt. It's a water-based gel. And so what we do is we'll go on the inside with a telescope, and then just under the mucosa, we inject this gel. We do it in 4 sites to create this sort of cushions here, and it sort of causes the urethra to coapt. The nice thing about it is it's minimally invasive. It's takes like 10 minutes. There's no real downtime. I would say the worst thing that can happen is it doesn't work. But in general, it's a lower barrier to entry for patients that want to do any treatment for stress incontinence. People can still have, typically with slings, which we'll talk about in a second, if someone has a sling and they still want to have another child, we typically want to wait till they're done having children before we would treat the stress incontinence, because the sling is going to get disrupted with the second pregnancy. And so this can be a lower barrier to entry for patients with stress incontinence. I've seen really good results with it. I think, like I said, the worst thing that can happen is it doesn't work. That it's been around for about 7 years now, so the data is 7 years out, and so we can't call it a permanent procedure, but in patients that have had a good response, it can last up to 7 years. And so, but we can't say permanent in the moment, and it's repeatable. So it's I think, like I said, most common thing is it doesn't work. Someone might get a urinary tract infection because we're going from the outside to the inside, some short-term urgency or feeling of incomplete emptying, but in general, it's a very minor thing. In kind of the gold standard is still the sling, and so those are still mesh and non-mesh, and obviously pluses and minuses with those different treatments. If someone hasn't studied up on urology lately, there's the typical sling, or the most common sling historically was a retropubic sling. Now we have this transobturator sling, which kind of goes across through the obturator foramen, and can be a little less traumatic, a little less painful, a little quicker recovery, but it's still a foreign material. Typically, if someone's going to have a retropubic sling, it can be mesh and non-mesh, but the transobturator slings are typically mesh. So high cure rates, typically 80% at 5 years. Obviously, complications with mesh, pelvic pain, erosion, infection, retention, de novo overactive bladder symptoms, and then some pelvic pain. But it's still considered the gold standard, but obviously a little higher barrier to entry compared to Bulkamid. Sorry, what we were talking about here was called Bulkamid. Again, we've been doing this type of procedure for a long time, but the product that we inject doesn't dissipate. That's what the difference is between this and what we've been doing. All right. And so, okay, so recurrent UTIs. So there is a definition for recurrent urinary tract infections. It's 2 or more infections in 6 months, or greater than 3 in 12 months. I always tell people there is a difference between infection and colonization. So I think one of the biggest things is a patient comes in for an annual physical, gets a urinalysis, has no complaints, and gets told they have a urinary tract infection and gets prescribed Bactrim or Macrobid or whatever. I always tell people infection is a bacteria, or so colonization is bacteria hanging out in the bladder, minding their own business, and infection is bacteria in the bladder throwing a party, causing symptoms. And so there's a big difference. And so we don't always have to treat every positive urine culture in those patients. And so that's, I think everybody's, I think, probably more worried about medical legal aspects of UTI treatments, but in general, if they're asymptomatic, you don't have to always treat all those patients. There are, of course, patients that we are going to want to treat. The pregnant patient that has bacteriuria, anybody that has any abnormal urinary tract findings, potentially kidney stones, those kinds of things, immunocompromised. A lot of the patients are on these all these immune modulator drugs these days. So that could be a reason to treat them. And then, of course, multi-drug resistant organisms. But in general, don't have to treat every urinary tract infection. I enjoy treating urinary tract infections or recurrent urinary tract infections. I think it's a challenge. There's always a rhyme or reason for it. And I tend to break it down into sort of 3 categories. So so bucket number 1 is environmental, bucket number 2 is anatomy, and then bucket number 3 is function. And so in the environmental category, I saw a patient the other day who has recurrent urinary tract infections, and the first question I asked is, do you wear pads? And she's like, yes. So of course, the pad is like a spider web for bacteria to hide in and cause a urinary tract infection. So if we don't treat the patient's underlying urinary symptoms or incontinence and they have to wear a pad, then it's just the perfect environment. It's a moisture-rich environment, and that's where bacteria like to be. So getting folks out of the pads. I tell most patients it's not hygiene related in that sense. It's not how they're wiping or the types of soaps they're using or type of underwear they wear or baths or any of that stuff. There's usually some other rhyme or reason. Most patients know how to wipe. That's not the issue. But pads would be sort of in that GU hygiene category. Fluid intake. So folks don't like water. If they don't like water, they're not very hydrated. They're not flushing that urine out, flushing the bacteria out. And so that's a simple fix. Bowel management, constipation can cause urinary tract infections in multiple ways. So one is if someone's constipated, they often don't empty their bladder as well. So that's common. And then if they're also constipated, that stool sits in the colon longer. They get more coliforms on the stool. And then if they have to push or strain to get that bacteria out, that stool out, then it's going to push that bacteria all over the place. So that's constipation management is a big one. Cranberry supplements actually do have good data, and it's supported by the AUA guide on or guidelines on recurrent urinary tract infections. I always tell patients it's not the juice, it's the supplements. So you'd have to drink gallons and gallons of the juice for it to have the same effect. And so you want to stick with the supplements. I don't have any brand preferences. I just tell them to pick it up at Costco or Kroger or wherever. And then topical estrogen. So for any peri or postmenopausal patients, huge benefit from topical estrogen therapy. It's not a hormone replacement. So we're not trying to increase serum levels of estrogen. It's a local therapy. I prescribe it pretty much every patient that I see that has recurrent urinary tract infections. I have to warn them about all the bold print that's going to come on the CVS or Walgreens, handout, but we're not using it as an estrogen replacement. We're just using it as a local therapy. They apply it twice a week. They apply it externally. They don't have to use the applicator. It can make a huge difference in UTI risk, can make a huge difference in pain with intercourse. It can make a actually it can impact overactive bladder symptoms. So there's a lot of great data to support topical estrogen therapy. So pretty much I tell people 80% of the problems are going to be in bucket number one as far as their problems. So if they're doing everything in bucket number one, we definitely want, if they're not, we want to definitely start that. And then we move on to number two. A woman with recurrent urinary tract infections who is actively passing a kidney stone that looks totally fine. And I think that's kudos to pain tolerance. I would probably be laying on the floor, but I've probably every month I see a patient that's had a UTI symptoms for 6 months, and we get some imaging, and they have a kidney stone that's passing, not just sitting in the kidney, but actually passing, and they're just minimally symptomatic from it, with exception of the UTI symptoms. So is an easy one, either from some kind of imaging to see if they have any issues there. A pelvic exam, you'd be shocked by how many times patients just don't get examined as far as, is their bladder falling out? Is there something else going on down there that's causing UTIs? Are there symptoms UTIs related, or is it something external or whatever like that? So a lot of times just doing an exam is helpful. So the anatomy is an easy one to check either through imaging or through exam. And then function is the last one. So that's kind of like how we alluded to when we were talking about InterStem, is that some patients don't empty. And it's not necessarily an obstructive process. They're just bladders don't squeeze. When you ask these patients, they'll say, yeah, I know that I don't empty. I get up, I sit back down, I kind of move on the toilet and jiggle around and try to get the urine out as best I can. I push, I strain. So they're doing all these maneuvers, and I just tell them that that's not normal. That's not a normal voiding pattern, whether that's new or something that's developed over time. That's just not how they're supposed to void. And then the overactive bladder treatment in and of itself. We give a patient these medicines, and of course, like I said, they're holding on to more urine. That's stagnant water, and that's where bacteria like to be. So, pretty much that's why I like UTIs, because there's always somewhere in there that is this little puzzle you got to figure out and where they're getting these UTIs from. So I'm not a big fan of suppressive antibiotics, unless we've kind of gone through this pathway and try to figure out what's actually happening. Obviously, you can use suppressive antibiotics, but resistance, side effects, they're not. It's not small. So I think kind of looking for the underlying cause is a challenge and fun to kind of figure out for folks and helpful. All right, so next one is hematuria, and so I think gross is pretty self-explanatory. You're visibly seeing blood in the urine. I think microscopic gets confusing. And not that I would turn away a referral from any provider that wants to send me a hematuria referral, but just so the patient doesn't waste their time coming to see us. Dipsticks alone don't count as far as microscopic blood in the urine. Often the microscopy will be normal because there's some confounders and other things happening or false positives, and so we do want to make sure that it's getting reflex to microscopy so that we can see if it's truly blood in the urine. And of course, blood in the urine is 3 red blood cells per high power field on the microscopy. And typically it's in 2 out of 3 non-contaminated specimens. So we don't see any epithelial cells, which would suggest contamination or picking up some of that from the skin. And again, it's not strict. Like I said, I won't turn away the referral, but in general, they don't have to see us until it's 2 out of 3 micros that are positive. Risk factors. So age over 40 for men, age over 50 for women, tobacco use, some kind of chemical exposure, any history of previous radiation therapy. There is patients have had prostate cancer radiation therapy. They can develop bladder tumors from that therapy. Anybody that has irritative voiding symptoms, bladder cancer can present as irritative voiding symptoms, much like overactive bladder. So if their urinalysis is normal, fine. But if their urinalysis is positive and they have irritative voiding symptoms, that's suspicious. And then in prior urologic disease or treatment, those are all things that would be considered risk factors for those patients. And the blood, I always tell people, can come anywhere from the tip top of the kidney or to the tip of the penis or urethra. For us physicians, glomerulus to meatus, basically. So anywhere in that whole filtering process, all the way to the exit, is where the blood could be coming from. And so that's where our evaluation is focused, at least urologically. If someone has these other things, the proteinuria and all this stuff, then it's, it goes on to the smarter folks, the nephrologists. We're just plumbers, So, but it's, it could be glomerular if you see the red cell cast, if you see the protein, and then I refer them to my nephrology colleagues, or you guys would. Otherwise, it is our territory if it looks like it's just not from the kidney. And then blood thinners, so many different types, but in general, even if someone's over anticoagulated on Coumadin, we should not see spontaneous hematuria or de novo hematuria. And so those patients still get worked up, even though the patients will try to convince me that it's X, Y, or Z reason why they shouldn't have a workup or have the cystoscopy, but it's not enough that they're just on Eliquis, and that's not going to cause hematuria. And in the workup, so for high-risk patients, so again, older patients, any kind of smokers, any tobacco use in general, they get a CT cystoscopy. So we do have to evaluate the upper urinary tract. We do have to evaluate the lower urinary tract. And so a urogram is just basically a specialized CT scan where they time the IV dye such that it lights up the ureters and the renal pelvis, so that way we can see the ureters. Again, a low risk area, but in high risk patients, we want to look at those areas. In low risk patients, so asymptomatic, no risk factors. So per AUA guidelines, again, you could repeat the UA in 6 months in general if they've already had the 2 out of 3. I'm not entirely sure why repeating the UA in 6 months makes a difference if they've already hit the criteria of 2 out of 3. But this is in the AUA guidelines. And so typically those patients could get by with a cystoscopy and an ultrasound. You could also do a CT urogram. I don't. Sometimes it's actually easier to get a CT urogram sometimes on patients than it is to get an ultrasound. But the idea is that you're looking at the higher yield areas for malignancy, which would be in the kidney and in the bladder. The ureters are a little bit lower yield, but you may that would be one area that's not evaluated in that and with those two studies, but in general, you're hitting the highest yield areas. So that's kind of how we would do the hematuria evaluation. And so then I just had just a couple of clinical things that I see and just wanted to just point out that were just random thoughts that I had. I still see this a lot, elevated PSA patients getting treated with antibiotics. If they're asymptomatic, they don't have, dysuria or frequency or urgency or actual signs of prostatitis. The idea of giving someone ciprofloxacin for 2 weeks or a month for an elevated PSA has sort of been debunked. It will lower the PSA because those medicines or antibiotics can have some anti-inflammatory properties. What it does do is eventually delay the diagnosis or this person going on to what they need, which is further evaluation for the elevated PSA. And then number two is that it can increase the risk of a post-biopsy infection because they've already had this exposure to antibiotics. So if I can say anything for if anybody's doing this out there, don't. And then for testosterone, I see this all the time as well. Patients getting tested for low testosterone and only getting checked for low testosterone. This is mostly the doc in the box men's health clinics or whatever. So I'm sure it's nobody on this webinar, but if someone has a low testosterone, especially if they're younger, we got to look at why are they having low testosterone. And so LH, FSH, if they're in their fertility years, prolactin, if they have any breast tenderness or any of this kind of stuff, or if they have a super low testosterone. I usually just check it all at the same time. I mean, you can technically order these tests after the fact, but it just makes it easier to check at the same time since you're already getting the blood draw. And then, of course, PSA for men that are over 40 in case they have low testosterone and you decide to treat it. But I've seen way too many times where folks have had a low testosterone and get started on testosterone therapy and they're 45 and I'm just flabbergasted that we didn't look into why their testosterone's low at that age. And then I get this all the time too. I get male patients who have urinary tract infections. Men should not get urinary tract infections. It's a long distance from the tip of the penis all the way into the bladder. And so typically if a man gets a urinary tract infection, there's typically an underlying etiology, either some type of obstructive pathology like a urethral stricture or bladder or prostate issues. It could be fluky, but it's not very common. It's not going to come from going into Lake Lanier or anything like that. I've heard that story too. There's usually some underlying reason that a man got a urinary tract infection. We may not have to evaluate those people the first time it happens, but it's definitely not normal and typically related to some underlying cause. So that's sort of my public service announcements about just some side urologic things that I see. I want to just make sure everybody on this webinar is up to date on that. So that's my final slide. And so I'm happy to go back to any of the other slides. I'm happy to go into a deeper dive. I know this was a little bit more of a general overview, but I just wanted to catch people up to speed on, kind of what's newer out there as far as treatments and why we, want to ask these patients about these issues because they don't have to deal with them. We don't want any sort of progressive issues with prostate stuff. I want to make sure they're getting referred over to us at the right time, not prematurely, all those kinds of things. And after that, I would just, open it up to the floor if there's any questions.
Thanks, Vishal. That was a wonderful overview of urology. At least I learned a lot, basically having too big an opening or too small an opening, both is a problem. If your vessel is too strong or too weak for the bladder, that's a problem as well. But very interesting talk. But as we have decided at GAPI, the first dips would actually go to our MSRF representative. So I would invite Harish Alappan, who leads the MSRF initiative, the Medical Student Resident Fellow initiative at GAPI, to start with any questions that he or his colleagues may have for you. So Harish, ball is in your court.
Hi, Dr. Bhalani. Thank you for your presentation. I'm a fourth-year medical student at Mercer in
Awesome.
Macon, Georgia. And so my question, I don't know if this is too specific or not, but I heard that there's a difference between TERP procedures. There's bipolar and
Yeah.
there's unipolar. So I was just
Yeah.
wondering if there is any difference with the indications um, with
That's a good
people who
question.
have cardiovascular disease or any electrolyte imbalances.
Yeah.
Uh,
So, yeah, I mean,
when you
so,
use which one?
yeah, I mean, in general, I mean, I would say, I guess and I think one of the sad things about medicine might be that, some of this technology might not make it everywhere, right? So, depending on who you see, you may only get offered a TERP, and I get a lot of second opinion TERP consults, because someone was offered a TERP because that's what that urologist knows how to do, and they're not necessarily offering these other therapies. So yes, there is a difference between sort of what we call bipolar and monopolar cautery, and so basically, and it's about conduction. So historically, we only had monopolar cautery, and so in that situation, um, the irrigation fluid that you would hang is not going to be physiologic. So it's going to be something called glycine, which is basically increases the risk of someone having what we call TUR syndrome or post-treatment hyponatremia and the complications that come with hyponatremia. And so when I was in residency in Chicago, we did 6 months at Cook County, and Cook County had monopolar TERPs or TERP set, and we had patients with 200 cc prostates, which is 10 times the size of normal. And so we would basically resect as fast as we could for 90 minutes or 2 hours, as fast as we could, as fast as we could. And then we would stop, and then we'd basically like let that person go to the floor and everything, and then we'd bring them back and resect the rest of their prostate because sometimes you'd have to bring them back in 2 sessions, but we didn't want them to get into TUR syndrome. So in general, yeah, I think monopolar cautery for the most part should be not being used. It probably is still used in some rural places, but in general, it shouldn't be used just because of that reason. So bipolar cautery is basically you can use normal saline irrigation, so there's not that risk of the hyponatremia. And then again, the treatments are kind of getting faster. So from a time perspective, you don't have to worry about it as much with bipolar cautery. But yeah, aquablation, for example, I typically or routinely treat 100 to 200 gram prostates in 45 minutes. And that's because the water jet basically vaporizes the prostate quickly. And then you basically clean it up after the fact. And so that's why it's a popular treatment potentially for larger prostates because you're doing pretty much the same job, but with less risk.
Awesome.
Thank you.
Yeah, for sure.
Any more questions from MSRF representatives in the audience, or if not, there's a question in the chat. There's a question from iPhone user 5. The question is, what prevents urinary incontinence in elderly? Any links for pelvic floor exercises?
Yeah. So I think in elderly patients, it's really going to depend on the type of incontinence, right? So, for example, if it's a man, we might see, like I said, overflow incontinence or maybe even stress incontinence because of maybe a prostate procedure that caused it. And then, of course, there's overactive bladder and urgency incontinence. So it always depends on the etiology. With stress incontinence, there is pelvic floor physical therapy, and I can post it later or whatever for a link for that. We have a handout that we give in the office to all patients for pelvic floor physical therapy. The difference between pelvic floor physical therapy for stress incontinence and overactive bladder is totally different. And so I think a lot of times patients have overactive bladder and they're told to do physical therapy, and then of course everything online is Kegel exercises and pelvic floor strengthening exercises. And the difference is sometimes that's the issue. You have tight muscles, you have tension there, and so you don't actually want to strengthen those muscles, you want to relax those muscles. And so an actual formal physical therapy evaluation and a program can actually help determine what type of physical therapy is important. So it's not just Kegel exercises, it's not just squeezing those muscles. There's a whole pelvic girdle system and different exercises and core and things like that. And so in patients with mixed incontinence, overactive bladder, and stress incontinence, like I said, I do find that referring them to a formal pelvic floor physical therapist is helpful because there are some muscles we want to strengthen and there are also muscles we want to relax. And you can make your overactive bladder symptoms worse by overdoing Kegel exercises. So like I said, in elderly patients, the most common would be, again, if it's postmenopausal or postpartum would be stress incontinence, but overactive bladder obviously plays a role there too. And they're two separate issues. And so typically, if you don't address the stress incontinence in patients, they might always continue to have urgency incontinence. And the reason for that is if there's a little bit of urine coming down the urine tube, that's the bladder's trigger to squeeze. And so if you have stress incontinence, even if it's mild, it could lead to overactive symptoms. And so a lot of times we have to treat stress before we can sort of completely improve irritative symptoms. Hopefully that answers the question.
Yeah, definitely. I think they need to first find out what's causing the incontinence.
That's right. That's right.
Pointed out that there are different causes, and then pelvic rehab is a niche, and you need specialized pelvic therapy if physical therapy is routed. So it's not something you can just look on the internet. Sometimes, as you pointed out, Kegels is actually.
Yeah, I mean, I always tell people it's kind of like getting it's like going and doing an exercise at the gym. You could do 100 of the exercise, but if you're doing it wrong, you're not going to get anything out of it. And so it's just like getting a trainer. They're going to coach you. They're going to make sure you're doing it right. They're making sure you're actually doing the right exercise for the right problem.
Yep. Another question, Dr. Satish Chetty is asking, when do you refer for prostate embolization?
So it's, honestly, it's when I trained in Chicago, we had a very strong interventional radiology program in conjunction with our urology program. And so we did a lot of prostate artery. I mean, we didn't do it, but we referred a lot of patients for prostate artery embolization. And I think at the time, some of these non-ablative therapies weren't as prevalent. And so I personally, I refer patients for prostate artery embolization, honestly, if their prostates are really, really big. They have a lot of more medical comorbidities where bleeding or they have to be on blood thinners. I do find that it would probably be a safer, less side effect heavy treatment. And it can also sort of reduce the size of the prostate and make them a candidate for some of the non-ablative therapies. So the big difference, I think, in ablative and non-ablative therapies is there are certain sizes and shapes of prostates that will benefit from the different types of therapies. So if your prostate's too big, then some of these non-ablative therapies might not be the best option. And so you can't really sort of squeeze a square peg into a round hole. You have to kind of assess the prostate size, the prostate shape, the bladder health. And that's honestly what determines the outcomes. And so I think the problem is, again, if you go somewhere where they only do one or two types of treatments, you're not necessarily getting the whole gamut of options. And I might have a patient that has a medium-sized prostate and it's very favorable for a UroLift, but they may say, "Hey, I would rather have something that lasts more than 5 years." And that's if sort of the counseling is important on what someone might choose. Someone may say, "Oh, well, if it's going to last 5 years and then I don't have to have a catheter or any sexual side effects, then I'd rather have that and do it again in 5 years if that's." And so I think that's where it makes a difference. So prostate artery embolization, I think, is one, we're seeing it a little bit more, I think, because honestly, it's a little bit financially driven, I would say. There's a lot of urology groups and practices that are bringing prostate artery embolization in-house. So there's a group in Alabama that is a big group, and they have hired their own interventionalists. And so now you're going to see Alabama's population is going to see a lot more patients getting prostate embolization because the urologists have something to gain from the treatment. So I think that's honestly how some things are driven, unfortunately. But it's a good therapy. It's not without side effects or risk. It's just, like I said, there's 10 options, 11 options, 12 options in prostate treatment. And so patients have to, one, be presented with all the different types of options so they can sort of make an informed decision. And I think that's probably the most important part of it.
Yeah, I think there was a add-on question to that. I'll jump to it. iPhone in there asked the question about prostate embolization and what are its drawbacks. I think you did cover that, but if you want to reiterate the drawbacks.
Sure, yeah. I mean, I think, so the drawbacks would be, it doesn't, there's no immediate effect. So it'll be like kind of a delayed improvement. There could be some inadvertent you know, embolization or some of the spheres or the coils that they use kind of going somewhere else or blocking something else. It's not as durable as one might think. And so, I think, like I said, I would typically reserve it for sometimes if folks are unhealthy or catheter dependent, or if they want to preserve ejaculatory dysfunction and they want something, sort of less risky, I guess. I find UroLift is a very good option for those patients. But again, it's picking up. So I have patients that it's just part of the discussion. So it's there isn't. I think size would probably be my biggest factor because it can basically shrink the prostate a little bit and kind of open up more doors for that patient's future treatment, right? All of us are probably going to eventually have one or two or three of these treatments, depending on how unlucky we are. But in general, we're all going to deal with this. And so some of the treatments, like I said, may last longer. Someone may choose prostate artery embolization today, and then 3-4 years when their symptoms return, their prostate's small enough, and maybe they'll choose, who knows, iTind or Optilume or UroLift. But unfortunately, none of these treatments are permanent, and so the reproducibility or the repeatability is also part of it.
Sounds good. A couple more questions. I know we are over time, but some user Desa is asking, can you address the PSA state of art info? You did cover a little bit about PSA, but just
Yeah.
you have seen PSA screenings in the mall, so it's an important topic.
Sure. Yeah. Yeah. I mean, I think, so I still think it's a valid test, right? It's, came out in the 80s. It's reduced the risk of, reduced the risk of men dying from prostate cancer by 40%, which is dramatically different from mammograms, for example. So it does work. I think the biggest knock on PSA, of course, is there's going to be a lot of false positives. And so nowadays there's, obviously there's more things we can do to find out if someone really needs to go on and get a biopsy, right? So we have free and total PSA, which is validated for PSAs between 4 and 10, which might give us an idea of is this more BPH or more prostate cancer. What it doesn't tell us is this high grade or low grade. So there are better tests for that. There's some blood-based markers, tons of them: Pro PSA, ISO PSA, prostate health index, 4K score. Those are all the blood markers or some of the blood markers. Then there's urine markers, ExoDX, SelectDX, all these different things. And what they're trying to do is just sort of say, okay, does someone have this concern for high grade prostate cancer or Gleason 7 or higher prostate cancer? So a lot of times, I always tell folks the PSA at this point just raises the flag, and then you usually get referred over to urology, and then we kind of take it from there. And we're trying to decide, does someone need a biopsy? And then so let's say one of those tests comes back higher concern. Usually we get a prostate MRI. Prostate MRIs do have false negatives. So I always tell patients there's a 20% false negative rate with prostate MRIs. And so if the testing is generally saying that you need a prostate biopsy, we still would recommend it, but it's we use the MRI more for targeting. I think one of the other sort of disservices, just as a side note, is that on the printed lab report, it gives you these ranges of what's normal PSA. That's from data from the 80s. Catalonos, who trained me how to do a prostatectomy, and he invented PSA. He was at Northwestern. He basically, it's like there's no absolute normal value of PSA. It sort of trends over time. If a PSA goes from 0.5 to 2, that's a big jump. It's still less than 4. So, unfortunately, I get a lot of referrals as soon as the PSA hits 4.1, even though their PSA had been jumping up, well before that. Fortunately, it's still probably early for those patients, but there's this sort of, I think patients get lulled to sleep, or providers might get lulled to sleep about using that graph on the printout, which is from the original data from when PSA came out in the 80s.
Yeah, so the rate of increase is more important than the absolute value.
Yeah, I mean, family history plays a role. So, I mean, I think the big disservice with the U.S. Preventive Services Task Force, shutting down PSA is that because during that 5 or 6 years that it was kind of like not covered, we now have seen that result. We've seen patients presenting with, more advanced cancer. And so I think it's back to testing it. I don't think everybody needs a biopsy. It's kind of like BPH treatments, right? Like people need treatment. Not everybody needs X, right? And so same thing with PSA. Not everybody needs a biopsy. Not everybody needs treatment. I think now we've tempered that a lot more than we used to. And so, but that's, but PSA screening is still life-saving.
Just as a side note, in countries like India, actually, they're doing a lot more PSMA PET CT guided biopsies than MR guided biopsies. We in the
Yeah.
US are actually not doing that. So just uh,
Yeah, I mean PSMA is just I mean it's just, obviously it's all the marker, right? So we had Oxymin PET CTs which weren't as accurate as PSMA, and so like I mean it's a cost related thing. So but in general, yeah, I mean the more targeted we can be with diagnosis, the better. And then obviously the future of prostate cancer treatment is targeting therapies also. So right, so like in the moment where we have focal therapy, but it's not quite as precise as pinpointing the tumor itself, which is obviously going to be the future of prostate cancer treatment eventually. But in the moment, that's all still newer.
one last question, and then we'll wrap up. You did cover it. There's a question from a Zoom user about comment on the medical therapy for BPH. You did
Yep.
mention the drugs, but on top of that, I would like to add, in addition to medical therapy, are there any conservative measures, lifestyle modifications, diet, and so on and so forth that you could comment on?
Yeah, sure. I mean, so as far as let's say supplements, let's say, I mean, the one that's been most studied in the US at least is saw palmetto. I'm sure there's tons of herbal or Ayurvedic remedies that we have
Mhm.
back home. But yeah, saw palmetto is the main one that we know about. And generally I always tell people if you want to try saw palmetto, the data is like 50-50, right? They didn't have good studies to kind of to cancel out the placebo effect of saw palmetto. And so if people take it and it works, great. If it doesn't, obviously we move on. But there are tons of prostate supplements out there. It's kind of like baby products. As soon as you put the word prostate on it, they're going to charge you more. And so I just tell people just get saw palmetto by itself. You don't need all the extra African this and that and other roots and stuff. It's pretty much saw palmetto. I think Costco used to have a prostate supplement that, again, the heavy lifter in most of these supplements is saw palmetto. So if you can find saw palmetto by itself, it's usually cheaper. As far as diet and lifestyle stuff, being overweight, constipation, all those things can kind of play a role. I think the drinking fluids late into the evening, the historical traditional dinner at 8 p.m., all these things from our standpoint, culturally are not going to help with nighttime urination. The having a glass of tea or a cup of tea before bed or whatever, any of this stuff is all going to be related to these urinary symptoms. So, it's an input-output problem at some point. And so after 5 p.m., I'm usually telling people to stop drinking fluids and front load the fluid. So we don't want people to not drink the fluid. I just want them to drink it all before 5 or 6 p.m. and then slow it down in the evening. That's kind of the diet and lifestyle sort of, mainstays. From a prostate health side of things. So historically, as darker skinned folks, our vitamin D levels are low. And so, the range of vitamin D, I think, is like 30 to 100. I typically tell my patients to try to be closer to 80 to 100. So that there's a relationship between low vitamin D levels and prostate cancer. And so that's a supplement that we recommend. Olive oil, omega-3s for folks that eat fish, they can get it from fish. Obviously, for folks that don't eat fish, they can get it from other sort of supplements. Generally, the Mediterranean diet is kind of the lowest incidence risk of prostate cancer worldwide, and so that's generally what their diet is focused on: less red meat, heavy omega-3s, and olive oil. And then tomatoes have lycopene, which is an antioxidant, and that's, interestingly enough, it's higher concentrations in ketchup and pasta sauce than there is in fresh tomatoes, but I obviously recommend fresh for everything else. But that's one thing that is in Men's Health multivitamins as well. So those are like kind of the general sort of prostate health recommendations.
Awesome. Yeah, tomatoes and all that is pretty important. So fantastic talk. I think we are a little bit over time, but great questions and great engagement by the community. And I would like to thank you again, Dr. Vishal Bhalani, for this scintillating talk and illuminating us with a lot of basic urology knowledge, which I think is important for both men and women. And if you have any questions, email us at GAPI and we'll have Dr. Balani answer them for you. And this
Absolutely, yeah.
has been recorded and it should be available on our YouTube channel for GAPI. It will be uploaded on our website. So,
Yes.
Excellent. All right. Well, thanks
Thank
for
you.
having me. Appreciate the
Thank you,
opportunity.
Vishal. Thank you, Amol, and thank you all the GAPI members and students and to joining us. And very informative section. And thank you, Vishal. Appreciate
Yep.
your
My pleasure. Thanks for having me. Have a good night, everyone.
You too.
Thank you.